Okay, so we have hyperpituitarism, and then if it's a adrenocorticotropin producing adenoma, they're going to have Cushing's-like symptoms, because the ACTH works on the adrenals to release corticotropin. Okay, so that's more rare. What is most likely to happen is that you're going to have too much growth hormone secretion. So this is going to present as, in adults, it's going to be acromegaly. In children, it's going to be dwarfism. So it can also present that if the child develops a tumor, so they're not born with the dwarfism, but if the child develops a tumor, they're still growing. So you have to think about, if we have too much growth too fast on children that are still growing, it can cause problems because of those epiphyseal plates. Remember bacterial anatomy? So what they'll do is they'll suppress the growth hormone in both of these cases. But it presents differently whether it's adults or children. Okay? Yes.
So could you go back to the stuff? So you said in children it's dwarfism.
No, sorry, gigantism. I did say dwarfism. I'm sorry, I meant gigantism. Thank you for catching up. Okay. All right, so Cushing's syndrome is where we have something going on with our pituitary, and the pituitary is secreting too much of that adrenocorticotropic hormone. It instructs the adrenal glands to release too much cortisol. Okay, your symptoms from hyperpituitarism is Cushing's syndrome. Most likely to have, like, the moon face is going to be significant. Sodium and water retention, truncal obesity, increased blood pressure, so, but the signature thing that you will see to differentiate like this between other disorders is going to be that moon face. And the reason why is because, you know, cortisol is a stress hormone, but it also regulates the metabolism of proteins, fats, and carbohydrates. Also influences the inflammatory and immune systems. So cortisol does a lot, and if we have too much of it, it causes those kinds of problems known as Cushing's syndrome. All right, so the way we diagnose this is our serum hormone levels again. Then the same things we've already talked about. You could do urine, we could do suppression test, MRI or CT if we think there's a tumor. Treatment depends on what is elevated. So like I said, if we have too much growth hormone, we're gonna give suppression therapy. We're just trying to balance whatever is too much in there. If it's prolactinoma, they can give a medication called bromocriptine. And then transsphenoidal surgery is where they go right up under your lip, just like that, and go through to the pituitary. So that would be an extreme case, like we need to remove a tumor, you know, depending on how big it is, obviously. Yeah. All right, symptom of inappropriate ADH. So SIADH, this is where you have too much ADH. Where does ADH come from? Is it the posterior? Pull up a picture. Yes. And ADH is also known as what? Or vasopressin. Very good. So causes are brain injury or neurosurgery, paraneoplastic disorder, but it causes fluid retention. So we have concentrated urine, dilute plasma, and hypervolemia. So this is the exact opposite of what? What did we see earlier? Diabetes insipidus. Okay, so treatment is going to be fluid restriction, slow correction of the hyponatremia, all right, so our thyroid, so your thyroid produces T3 and T4. Iodine is required for synthesis. Thyroid disorder is more common in women. Primary thyroid disorder is most common. Do you remember what we talked about? Primary, secondary, and tertiary? Said tertiary is not very common. Which one was primary? Well, what was the primary reason for the endocrine gland itself is dysfunctional? So, and what was secondary? Yes, abnormal pituitary sending abnormal signals to that gland. Okay, so primary thyroid disorder is the most common. Enlarged thyroid can indicate hypo or hyperthyroidism, and this is what that looks like. It's called a goiter. May develop with excess TSH, thyroid stimulating hormone. If you have low iodine levels, because remember we said the iodine is needed to synthesize your thyroid hormones, or goitrogens, which are foods or other substances that promote thyroid gland enlargement. I think that would be less common. Your hypothyroidism is typically, so this means we have not enough thyroid hormone, okay? In converse, because we're sending those signals back, we have not enough thyroid hormone. What are you gonna have an excess of on your labs? TSH is gonna be elevated, okay? You gotta understand that. So it's the opposite. So if my thyroid hormones are low, we're gonna have excess TSH. Okay, so if I gave you a test question and it just said the patient's lab value indicates low TSH, then what do you think they have based off of just that? Hyperthyroid. Okay. All right, so Hashimoto's thyroiditis is an autoimmune disorder. This causes anti-thyroglobulin antibody and peroxidase antibody. Other causes of hypothyroidism are drugs, genetics, thyroiditis, where it's just the functioning of the thyroid is inappropriate. This postpartum period, so after you have a baby, it's especially at a higher incidence of that. So most people that have babies also have their thyroid levels checked. And then congenital hypothyroidism, which is called cretinism. So, right, so those are some of your signs and symptoms. So hypothyroidism, I think we don't have enough of those hormones. We're gonna have that dry skin, we're gonna have hair loss, I'm gonna be extremely fatigued, I'm gonna have weight gain, menstrual disturbances, intolerance to cold. Those are your, this is your classic hypothyroidism symptoms. But if you know one, you know the other, because it's gonna be the exact opposite, okay? So, all right, hypothyroidism, what we're gonna do is we're gonna replace the hormone. So we're gonna give levothyroxine. You can give that orally. If you learned about those endocrine drugs, you're gonna know that we can give this. You guys remember when we typically give it? In the morning before they eat breakfast. That's right, good job. That's like, a lot of people have hypothyroidism. A lot of people have to take, levothyroxine or Synthroid. So it is a common medication that you will see if you are working, especially in the hospitals. It's a common medication that I give all the time, okay? Surgical intervention if necessary, not usually, but it depends on what's causing the thyroid issues. Myxedema coma is a severe hypothyroid condition. Will progress to confusion and coma if left untreated. So just know that that's a medical emergency. You'll go more into that later. Our hyperthyroidism, exact opposite. We have elevated levels of T3 and free T4. This is called Graves' disease. Hyperthyroidism is called Graves' disease. It is the most common cause, and it is autoimmune stimulation of the thyroid gland. All right, so you have thyroid stimulating antibodies that are going to bind to the thyrotropin receptors. Therefore, you're going to have gland enlargement and continual synthesis of thyroid hormones. Okay? Too much T3 and T4. Some of your symptoms over here. Your most likely symptom, though, is going to be goiter is more likely to happen in your Graves' disease, but it can happen in either. But to differentiate, your Graves' disease is where you see the eyes that are, how does it label it there? Bulging, big round eyes. Bulging is good. Graves' ophthalmology, or bulging eyes. So that's how you can differentiate, visually. But just the opposite, they're gonna have anxiety, irritability, sensitivity to heat. So they're gonna be hot. They're gonna have weight loss without any changes, changes in our menstruation, heart palpitations. Heart palpitations are common in people with Graves' disease or hyperthyroidism. So there's and what we can do is we can give an anti-thyroid hormone medication called propylthiouracil, PTU, and then radioactive iodine treatment, which would be like for severe cases. Surgery, if gland is removed, replacement thyroid hormone is needed for life. So if we remove the entire gland, we still have to have that thyroid hormone to regulate, right? So then they'll be on the levothyroxine or Synthroid. You'll see those both. It's the same name, but that's your brand. But in the hospital, we don't. I know we teach you guys like levothyroxine, but what we do and what we teach. So that's not my fault. I'm just giving y'all both names. But so just know that if you have hyperthyroidism and we remove that thyroid gland, they're gonna have to be on that levothyroxine for life. Okay, this is a common thing that they do. So this is not like your radioactive iodine treatment, less common. But surgery, they'll just say, okay, well, we'll just take out your thyroid and give you thyroid medication for the rest of your life. You're good. All right, thyrotoxic crisis, also known as a thyroid storm, overwhelming release of those thyroid hormones. It stimulates metabolism. They're going to have a high fever, tachycardia, agitation, and even psychosis. Often precipitated by surgery or trauma, it is a medical emergency. Just kind of be familiar with that name and know that it's a medical emergency. Overwhelming release of those thyroid hormones. All right, parathyroid gland. So there are 4 pea-sized glands on the posterior parathyroid. So posterior thyroid secretes that parathyroid hormone. It is released when your blood calcium is too low. So trying to think about how all right, so it's going to activate bone resorption, intestinal calcium absorption, and intestinal calcium absorption by those kidneys. So you need to know what your parathyroid is important for. Calcium. All right, so if you have hypoparathyroidism, it's very rare. This is like when we have inadvertent damage with thyroid surgery. It could be genetic disorders, but they're going to present with hypocalcemia, right? So our parathyroid hormone increases our calcium levels. So they're gonna, if we have hypoparathyroidism, they're gonna have low calcium. Have y'all learned about Trazals and Chavox? Whatever it's called. So they'll have those, which are just signs of hypocalcemia. Muscle cramps, tetany, convulsions. So we obviously have to fix this. Our our treatment is going to be replacement parathyroid hormone, and then we just want to normalize those serum calcium levels to prevent further complications. If we have hyperparathyroidism, this is usually due to a parathyroid adenoma. This means we have too much parathyroid hormone. We're going to have elevated PTH and calcium levels. If it's primary, which means with the gland itself, if we have secondary, it's going to be elevated PTH but low to normal calcium. And this is usually caused by hypocalcemia induces like secondary. So if, there's all kinds of other things that can cause hypocalcemia. So therefore the hypocalcemia is telling the body, hey, I don't have enough, or hold on. Yes, the hypocalcemia is telling the body to, increase that parathyroid level, right? And so you're gonna have elevated PTH but low to normal calcium. All right, our cortex and medulla of the adrenal gland. All right, this is where we talk about your glucocorticoids and your mineralocorticoids, also known as your cortisol and your aldosterone. If we have adrenal insufficiency, secondary is you're gonna have decreased ACTH, your adrenocorticotropin hormone. Primary is also known as Addison's disease. So this is why why I wanted you to differentiate between primary and secondary. Primary is with the gland itself. Secondary is a problem with the hormones. So primary Addison's disease, we have a problem with that adrenal gland itself. It's going to have autoimmune destruction of the adrenal cortex. Okay. You can have hypoadrenalism, so related to glucocorticoid use. So hypoadrenalism can be due to exogenous, outside the body, originating from outside the body, glucocorticoid use. So with prolonged use, it signals to the adrenal cortex to be suppressed. Did y'all learn about this in pharm? Y'all didn't learn about prolonged glucocorticoid use? That's important. So basically, in a nutshell, what this says is you don't want your patient to be on steroids any longer than they have to. Because it suppresses their adrenal gland and puts them into a hypoadrenalism. That's all that says in a nutshell, in Ms. Boswell's terms. So just know, also, what does steroid use do? It suppresses your adrenals, but it also suppresses your immune system. So steroid use only for when we have to have it and for the shortest term possible to do what we need it to do. Also, you don't want to abruptly stop your steroid use. And when we say steroid, that's a broad term. That's not what we think like street roids. This is steroids, glucocorticoids, mineralocorticoids. So you don't want to abruptly stop because the individual may be unable to respond to stressors. If you abruptly stop that because it takes time and the adrenals are suppressed, it's not going to be able to function to stress. Our adrenals release cortisol, okay? And if it can't respond appropriately, it causes all kinds of problems. So your adrenal, your Addison's disease, or your primary, this is that autoimmune response to those, dysfunctional gland, adrenal gland. These are what your symptoms are going to be. Postural hypotension, hypoglycemia, GI disturbances, weakness, weight loss. So if we get into an adrenal crisis where we can't respond, as if we abruptly stopped our corticosteroids, that's where you get into vascular collapse, your dehydration, your renal can shut down. So cortisol controls a lot in the body. We need that steady flow. The body will compensate, but abrupt stop is not good. And we know that cortisol influences our blood pressure, it influences our blood glucose levels. All right, so they'll do, most likely to do like a rapid ACTH test. So with adrenocorticotropic hormone administration, cortisol should rise within 30 minutes. So this is the only one where we would most likely do more of this, what did they call it? Not, more suppression test. So we would do more of this, like either suppression or to, like, we would test it this way versus serum blood levels for Addison's disease. So they're gonna give the adrenocorticotropic hormone, and then cortisol should rise within 30 minutes. No cortisol rise, we have adrenal cortex insufficiency, Addison's disease. All right. And then the treatment is gonna be daily replacement of glucocorticoid and mineralocorticoid.
I got a question.
Uh-huh.
So when you mean that the cortisol should rise within 30 minutes, are you mean like everything should get back up, like elevated back, right?
So in a normal response, when our body releases, like, our parathyroid releases that ACTH, and it sends the signals to our adrenal glands will typically respond in 30 minutes with an increase in cortisol. That's our, like, fight or flight. And if it doesn't do that, and then our body has those changes, our blood pressure, like, so if it doesn't do that, then you have Addison's disease. Hyperadrenalism is where we have hypercortisolism, or better known as Cushing's disease. So Addison's and Cushing's disease are opposites. This is where, all right, so primary is we're gonna have a problem with a tumor in the pituitary, right? So we're gonna have elevated adrenocorticotropic hormone. And remember how I just said, like in a stress response, what happens? Basically, in this, it's happening all the time, inappropriately. So we have too much cortisol, too high cortisol levels. So we're constantly in that stress mode. And we all know, just think about what stress does to our bodies. We grow. So your elevated cortisol levels, or conversely, people that get exogenous steroids, like, I don't know of adults that I've seen this in, but I know in kids especially, they have that moon face. Like, it is very round, like steroid face. It's just from having to be on steroids. People that have to be on steroids for the rest of their life.
I said it kind of did.
Yeah, it makes them like that round moon face. All right, some of your symptoms. Thin extremities with that truncal obesity, moon phase, personality changes, hyperglycemia. Addison's disease was hypoglycemia. Sodium and fluid retention, related to the RAS system. Another visual. Alright, so like I said, cortisol does a lot in our bodies. So if we have high cortisol levels, it's gonna block the action of insulin. So you're gonna have also have an glucose intolerance and hyperglycemia. It's gonna inhibit bone formation and accelerate bone reabsorption. So these people with high cortisol levels are gonna have osteopenia, possibly osteoporosis. Suppresses the immune response and hypertension. All of those things we've already said. All right, diabetes. So disorder of carbohydrate metabolism. You're gonna have high levels of blood glucose, body's inability to produce or utilize the insulin. These patients have a increased risk for morbidity and mortality, CVD, cardiovascular disease, renal damage, peripheral vascular disease, neurological disorders, blindness, and amputation from elevated blood glucose levels. So I would definitely note those things. Okay, that's important. Diabetes is the one we're going to talk about the most. It's probably the most prevalent, other than hypothyroidism. Diabetes is important. So if you don't pay attention to anything else, just make sure you got your diabetes down pat. Okay. If you find that I skipped over things, like if you're reading the book, if you're a book reader, or like pheochromocytoma, like I may have skipped over things because they're not as common and we're not going to get into those things. I tried to pick out the things that are the most common. Okay, if it helps you, which it would me, like compare, like put your hyperthyroidism next to your hypothyroidism, put your Graves' disease, but put those hand in hand so you know, like, this is too much and it's caused by this. Okay. All right, so we have 4 types of diabetes. We're really only going to talk about 2. So type 1 and type 2. So type 1 is a primary problem of the gland itself. Where does diabetes originate? What gland are we talking about? The pancreas. So the pancreas is unable to produce insulin. Okay? Does anybody know the cell that insulin originates from? Beta, what was it? Yeah, I heard islet of Langerhans, yes. So that is the specific cell that produces insulin. People that are type 1 diabetics, they do not have this function. They cannot produce insulin, period. Type 2 diabetics, they just have an inability to utilize the insulin or to produce enough of it. They produce it, but it's in too little amounts to be what needs to be to maintain glucose levels. Okay? You can get to where just because you have an adult, and typically your type 1 is an autoimmune response on those islet beta cells of Langerhans, islet of Langerhans. You said it so beautifully, Langerhans. So type 1 is that autoimmune response. It's typically seen in childhood. That's why you may think that it's childhood diabetic. There are people that don't find out that they have diabetes until later though. It's still type 1. It means that my cells no longer function. I cannot produce insulin. I'm type 1. Type 2, you can get to where you need insulin. You can be an insulin dependent type 2. Type 2 is lifestyle. A lot plays into your type 2 diabetics. That means that either genetically, lifestyle, like our environmental factors, has decreased our ability to utilize that insulin or produce enough of it. Okay? And then about, do you think it's more prominent to have type 1 or type 2? Yeah, 2. So our type 2 is about 90% of people with diabetes. Okay? Less than 10% with type 1 diabetes. So, increased diabetes has paralleled obesity increase. So that means as the obesity levels increase, so does the diabetes risk. Sedentary lifestyle is a huge risk factor. It is known as a polygenic disorder. And like we just talked about, there's environmental factors. So in most cases, type 2 diabetes is very modifiable. We can't modify our genetics, but we can modify our lifestyle. We can modify, our food levels, things like that. Food levels, food intake. All right, so type 1, autoimmune destruction of those beta cells. Antibodies are going to be present. So if we were trying to, somebody comes in, we have a 14-year-old that comes in, and they are, this is new. We're thinking 14, okay, maybe it's type 1, it's type 2. How could we differentiate based off of that? Well, that's kind of hard to do. That's kind of hard to detect whether you make any insulin versus. Yes, a titer test for antibodies. Okay, so if you have antibodies present in type 2 of the autoimmune, because of the autoimmune destruction. In type 1, sorry. So to differentiate between type 1 and type 2, they can do an antibody test, and antibodies will be present with type 1, not with type 2. So type 2 is going to be a more gradual onset. You're going to have increase in insulin resistance. Insulin is still being produced. It's just increased insulin resistance. All right, so insulin supported process of facilitated diffusion moves glucose from blood into the cells. So you need insulin to move glucose from blood into the cells. So just make sure you're familiar on your terminology here. Glycogenesis is glycogen formation. Glycogenolysis is glycogen breakdown. So you remember that lysis. So glycogenolysis occurs when blood glucose falls and the body needs energy. So it starts breaking down that glucose or glycogen. Gluconeogenesis is where amino acids and glycerol of lipids, also known as fats, are converted to glucose. So, how is this significant? So your fatty acids are gonna remain as lipids. They're converted to acetoacetic acid and beta hydroxybutyric acid and acetone. This is known as ketones or keto acids. Okay, it's red. This is gonna produce a fruity odor in the breath, saliva, and sweat. You know how everybody, like, I don't know, maybe not y'all's generation, but like everybody's been doing like the ketogenic diet, even if they're not, because of what happens when you basically starve yourself. You'll see it causes the body to break down into these acids, and it produces ketones. What it also does is the body's response to that. I'll show you. All right, so if you have an accumulation of the ketones, it leads to DKA or diabetic ketoacidosis. So develops in those with no insulin reserves. So if you're not a diabetic, it's very unlikely that you're going to go into diabetic ketoacidosis. High levels of ketone formation. 1/3 of children with type 1 diabetes are going to present first in DKA. So this is our type 1 diabetes. They show up at the emergency department because they're acting off. Maybe they're lethargic. Mom, dad says something's not up. They're not acting themselves. They might be vomiting. And they test them and they have severe high levels of ketones present, which is almost like a type of sepsis in the blood. So diabetic ketoacidosis. It's a critical condition and it's going to require immediate treatment. So that is a medical emergency. And how most type 1 diabetics present. All right, so starvation or inability to use glucose. So this is what I was talking about, everybody on the ketogenic diet. What happens is, so you have insufficient intake of the glucose, which is going to be hypoglycemia. All hypoglycemia is low glucose levels in the blood. The body cells are going to sense starvation. Therefore, the liver begins to break down the glycogen into glucose. Okay? The glucose from the liver increases in the bloodstream. So we're going to dump from our liver into our bloodstream that glucose because our body cells told us to, said that we're starving. Okay? Glucose from the liver increases in the bloodstream, and then when the liver glycogen is exhausted, fat breakdown begins. So our ketogenic diets, this is why people do that. You are going to have a fat breakdown, but we're also going to break down muscle. Okay? So this is your fat breakdown is going to be converted into fatty acids, which is ketones, and then glycerol to the liver to manufacture glucose via glucogenesis. And then the amino acids, same thing. And this is going to raise your blood glucose. So with that diet, the way people know that they're staying in the frames of the diet is they check their ketones and they want to stay they want to have ketones present in their urine. And so, yes, you are breaking down fat, but you're also breaking down muscle, and you're also telling your body to dump every little bit of glucose that it has into your bloodstream. So over time, think about how that might not be the best option for long-term weight loss. All right. Normal blood glucose levels are 70 to 100. my blood glucose is probably low. Alright, if your blood glucose gets below 70, that's when we talk about brain functioning being affected. We don't know what that level is, it's gonna be different for everybody. When you do a blood draw, like a finger stick, it's gonna give you a number, but it's within a range of what that number actually is. So, for instance, when I do blood glucoses on babies, I've gotten as low as 9 before. The baby was crying and awake and fine, and I'm like, I sent it back to the lab, or I sent a true off to the lab, because you know the ones we do on the machine is rapid, right? Sent it to the lab and it came back as 14. That baby was tolerating very well, but we don't know what the level of brain damage, at what point does brain damage occur. Like we're not gonna do studies on that. There's no way to do studies on that. And so at some point after, you know, when we get below 70, that's why when somebody is hypoglycemic, you'll start to see like slurred speech and like headache and like brain damage can occur. So our bodies function really well if you're not a diabetic, and you know, we compensate and we'll start going into, you know, glycogenesis and whatnot. But somebody who's diabetic doesn't have that ability, and it'll just drop and drop and drop. So we have to make sure we give them something to make it raise. Do y'all remember the medication? Also hormone, what is it? Glucagon. Yeah, so glucagon is produced also with insulin. And so glucagon increases that blood pressure or blood sugar, and insulin decreases that blood sugar. So that balance. All right. Know that you're postprandial. You know that means their glucose, their blood sugar after they eat. Postprandial. Y'all remember what ACHS means? Please tell me y'all learned this in endocrine farm.
Oh, before meal,
Yeah.
and at bedtime or something?
Yes. Y'all did learn that, right? That doesn't even sound familiar? Now I'm worried. Y'all want me to come teach y'all farm? Probably not. You probably don't want me to. Oh no.
So we taught ourselves that.
Oh no. Okay. Okay, so yes. So you need to know your normal glucose levels. ACHS. What'd you say it means?
C is before meal, and then HS is at bedtime.
Yes. So typically your blood glucoses on your insulin patients are gonna be checked ACHS. So pre-meal, and then, so we know how much insulin to give them. And then, before they go to bed. Huh? Okay, good. That got me worried. All right, role of insulin. So, this picture helped me. Like, you have to have insulin to allow glucose into the cell. So, just that concept, like, was helpful. So, insulin facilitates glucose uptake by the cells. So glycogenesis occurs in the liver and the muscle, and then fat is that's your fat sparer. Insulin is an anabolic hormone. So a lack of insulin is going to cause an increase in glucose in the bloodstream. Okay. Insulin, because it's just floating out there in the bloodstream, it needs to attach to something, and it can't because we don't have insulin to let it into the cells. That makes sense, right? Yeah, no, okay. So insulin signals your body to store the fat, and it empties your bloodstream of fatty acids and glucose, shunting them to your fat cells. So that's why I call it the fat sphere. If you have an increase in the cells, then the bloodstream level is going to fall, okay? So we have insulin, we've let it into our cells, which is appropriate, that's what we're supposed to do. We've let it into our cells, and now the bloodstream level falls. So if I check somebody that I suspect is a diabetic and I check their blood sugar, I can expect that it will be high, low. I have somebody that's a diabetic and they've just eaten, I'll add that, they've just eaten a candy bar. They have to eat, right? They've just eaten a candy bar. Can I expect their blood glucose level to be high or low? High. Because what don't they have? They don't have insulin, so therefore they can't pull that insulin into the cell. Therefore that insulin is free floating in their bloodstream. And so their glucose is, they don't have insulin to help pull the glucose into the cell, therefore that glucose is free floating in that bloodstream. And therefore, their glucose levels are going to be high after a meal. So, can it drop low? Yeah, I mean, if we give them too much insulin and they didn't eat, they thought they were gonna eat, they didn't eat, and we just gave them 10 units of insulin, because that's what they normally get, but then they just didn't feel like eating today. Well, you can expect it to drop. So just know that role of insulin, because that's important to connect those dots. Giving insulin makes it make more sense. All right, so we also have already talked a little bit about glucagon. We know that the alpha cells of the pancreas release glucagon when the blood glucose levels are low. Remember I said that balance? So that's also why we give glucagon to people that have low blood sugar to get it up. It's one of the medications, really the only medications, glucagon, that we can give them to make it go up, okay? Somatostatin is a delta cells of the, released in the delta cells of the pancreas. It also influences your insulin and glucagon. All right, so I talked about cortisol already from the adrenal cortex. It's going to increase your blood glucose. So if we have, that's why people with Cushing's disease, they have hypercortisolism. So they have too much cortisol, therefore they're at risk for what? Hyperglycemia. All right, so epinephrine also from the adrenal medulla increases blood glucose. We have some other hormones, incretins, that are GI glucose regulating hormones. We're not going to dive into those. Just know that there's other things that influence, but what you need to know is and understand is your insulin. All right, so we already talked about this. Pathological mechanism of type 1 diabetes is that T cell mediated attack of the beta cells. There is a genetic influence. They often present in DKA. And your classic triad, remember anything that we say is a classic, your classic triad is polyuria, polydipsia, and polyphagia. So too much urine, too much, yes, polyphagia. So So you're gonna have cellular insulin resistance with increased insulin levels, in type 2. So, that's what it means when it says insulin resistance, is that cell is becoming, we're not letting that insulin in, or we're not letting that glucose, that insulin attach or that glucose in. So that the cells are becoming insulin resistant, okay? So that develops, it takes time. There's something called metabolic syndrome, which is where you have hypertension, dyslipidemia, which is your lipids, LDL, HDL, okay? High LDL, hypertension, and then hyperinsulinism, so I'm producing too much insulin, and centralized obesity is called metabolic syndrome. So it's kind of when those all go hand in hand, they just label it as one thing. There are a lot of people that have metabolic syndrome, okay? Very influenced by our lifestyle. Hyperosmolar hyperglycemia syndrome is severely elevated blood glucose for a prolonged period. So DKA does not typically occur in type 2 diabetes. Why? Because the presence of some insulin prevents the ketone formation. Okay? Severe dehydration and confusion. So HHM is severely elevated blood glucose for a prolonged period. And this is with your type 2. This is not your type 1. This is only type 2 that are going to experience this. Because the opposite of that, if I have severely elevated in type 1, that's going to send me into DKA. Does that make sense, that differentiation? Yes.
For the metabolic syndrome, are you basically saying because of those, I guess, the things that they have, that's why they have type 2?
Who knows which one came first, the chicken or the egg? But it's
Like their hand in hand, basically.
yes,
Okay.
yes. And it's just a common, term. It's not an actual disease or disorder. It's just a common cluster for those, when those things come together, they call it metabolic syndrome. And they all influence each other. Remember how your glucose levels are going to affect your blood sugar or pressure levels because of the cortisol, and they all go hand in hand. And then if you want to go a step further, remember how we talked about the endothelium cells? The endothelial cells and how that causes damage, so you're at risk for, and you have high lipids, and then you have, that's why you have your peripheral vascular diseases. So they all just kind of go hand in hand. Yes.
Is that where we get the metabolic acidosis from?
Do what?
Is that where we get the metabolic acidosis from? That metabolic syndrome, or that's
Two different things.
Okay.
Now, probably associated with that, but it's two different things. That metabolic acidosis is more of like a short-term thing. This is happening. Like, you come in, you've been vomiting. Oh, we check your blood and pH, and you're acidotic. It's not the same. All right, the way we test them is fasting and a random blood glucose test. You can do an oral glucose tolerance test, OGTT. So that means we give 75 grams of glucose to them, they ingest it, and then we're gonna measure their blood glucose following. So, just like I said, that candy bar, we give it to someone, we give that candy bar, and normally their cells will release the insulin will turn that key and open up those cells to allow the glucose in, right? Well, if it doesn't do that, and we have a high level after we have ingested this candy bar, then you've got some diabetes going on. And we can differentiate between the two by how?
Tysis.
Yes, an antibody test. You're gonna have antibodies in which one?
Type 1.
Type 1. That's right. Good job. All right. Glycated hemoglobin is also known as your hemoglobin A1C. This is your diabetic or your glucose levels over 3 months, like 3 preceding months. So this is a better evaluation than a one-time fasting glucose. So typically when you go to the doctor, they're gonna get your hemoglobin A1C level, and that is over those 3 months, what has my blood glucose regulation been? It's gonna come out as one single solid number, and then you don't have to know what those levels are, but like once you get over, like, it depends. A level for someone who's, you know, active, and it depends. So if you already have other risk factors and you come to me with a level of 7, then that's more worrisome than if somebody's, you know, and maybe it was the holidays and they just ate a lot the last 3 months. But it's a better representation is that over 3 months hemoglobin A1C. All right. So also you may have, in diabetics may have glucosuria, which means they're dumping glucose into the urine, okay? They'll have that because the glucose levels exceed the transport maximum of those nephrons. So there's too much insulin in there, we gotta get rid of some, so it starts dumping it basically into the urine. So that's a sign of diabetes as well. Because remember, it can't attach because we don't have that insulin. It's just in our bloodstream. Also the ketone formation, more likely to see ketones in type 1 diabetic. Although people who are on a ketogenic diet, they try to stay in ketosis. It's very, very hard to do. You are essentially starving yourself. And it's hard to do because our body pulls from every other place to get that where it needs to be. So more common in your type 1 to produce ketones in the urine, and they occur when glucose cannot be utilized. Okay, so complications, both acute and long-term, are present for both hypoglycemia and hyperglycemia. Acute for type 1 is your DKA, and then acute for your type 2 is your HHS, hyperosmolar hyperglycemia syndrome. So remember I said that's when you have high blood pressure or high blood sugar for a prolonged period, because we've become more insulin resistant. Those cells have become more insulin resistant. It's not letting that glucose in. That glucose just continues to hang out in our bloodstream, and then that is your acute. So your long-term are gonna be systemic problems from, think about, I have a high amount of glucose that's free-floating in my bloodstream. You're gonna have problems with blindness because it has those endothelial cells in our vessels. It damages them. High glucose levels are going to damage those cells. Think about like where we need those tiny little, like that's why you have the blindness, is because it damages the capillaries and things of our eyes, okay? That's where that comes from. Kidney failure, neuropathy. What is neuropathy? Nerve damage, yeah. So you're gonna have decreased sensitivity in like those extremities, nerve damage, which is gonna put you at risk for injury, what'd you say? Limb loss, yeah, so, but it's gonna go, I have tingling and decreased sensitivity, and then I stub my toe one day, and I don't even know I stubbed my toe. Oh, shoot, I got an infection. Dadgum, didn't even know, didn't feel it. That's how that goes. They're more at risk for ulcers because of the blood vessel damage from those high glucose levels is gonna damage those vessels, therefore, they're gonna have peripheral vascular disease, okay? So if I can't get the blood down there to get where it needs to do to get the oxygen to help heal it, then I'm gonna have ulcers, non-healing. That's why you have your delayed healing in your diabetic patients. It's all because of those high glucose levels. Same thing, cardiovascular disease. All right, so hypoglycemias, if we get less than 70, if you have too much, you didn't eat and I gave you too much insulin. That's where we talk about excessive exogenous, outside insulin. Inadequate food intake, excessive physical activity, that's important. I guarantee you that you will probably see that. There's gonna be a question, and it may not be from me, it may be from NCLEX, I haven't made the test yet, so. But there's gonna be a question, and it's gonna be like, Jane has type 1 diabetes. Jane's going to go for a morning run. Like, what do you need to do? And it's gonna be referring to like, do I need to hold the insulin? Do I need to give extra insulin? Do I need to, like, it's gonna, because when we have an excessive physical activity, it's gonna put them more at risk for hypoglycemia, okay? So their physical activity is going to influence those glucose levels in your diabetics. Infection, illness, and drug interaction. So same thing, if you have somebody that has an infection or an illness, they're more at risk for having, that is a diabetic, they're more at risk for having those fluctuations. So compensatory response to raise the blood glucose is why we get most of our symptoms. They become anxious, sweaty, hungry, confused. They may have blurred or double vision, shaky, irritable, cool, clammy skin. That is because of the compensatory response we release epinephrine and we release glucagon and we activate our SNS, okay? So all of our symptoms are caused because of that. We're trying to compensate. All right, so to jump into action, we need to give them fast-acting carbohydrates. 15 grams is the recommended. Okay, so fast-acting carbs, we want to give them some crackers, some carbs. We want to avoid fats because fats are going to delay the glucose absorption. Okay, so we wouldn't want to give them, I don't know, what's something fatty? Chicken? I think chicken's protein. I'm trying to think of like fat. I mean, avocados are fat, yeah. Cake. Cake has carbs, but just know that like if you're gonna pair it, like give them some crackers, maybe not like the cake. Something fatty. I guess like fried chicken. Yeah, fried chicken's fatty. Okay, so so transient response, that's where we talk about if anybody has a blood glucose less than 70, we want to go ahead and provide a snack, that 15 gram high carb snack, because their body, it's a transient, they're going to drop further. Repeated episodes of hypoglycemia can blunt the compensatory response. Okay. And then if it's too low, we can give them IV glucose or the glucagon by subcutaneous injection. Okay, this just goes a step further into the classic signs. So polydipsia, what you have is a high blood glucose increases your plasma osmolarity, and the fluid shifts from the ICF into the ECF, and then therefore you have increased thirst. So this is your reason for your symptoms. This is your true pathophysiology behind why they have these symptoms. Okay. Polyuria, you have increased thirst and drinking. You're gonna have osmotic diuresis. You're gonna have dumping of glucose in the urine. Water follows glucose, therefore increasing your urine output. Visual showing those fluid shifts. Polyphagia, so if the body cannot use the glucose, that's when we're gonna have fat and muscle breakdown, weight loss with increased appetite, and ketone levels may elevate, okay? So we're hungry. Blurred vision happens because of accumulation of the glucose in the aqueous fluid of the eye. Electrolyte imbalances are going to occur because of the fluid shifts. Potassium is going to move out of the cells, therefore creating a false hyperkalemia. So serum levels of potassium are going to be elevated, but total body potassium is not increased. So this is just talking about the utilization, basically everything that we just talked about. Long-term complications. So chronic hyperglycemia leads to damage of small and large arterial vessels. Everything we've just talked about, vascular damage, angiopathy, leads to downstream in-organ damage, your kidneys. Retina, glomeruli, and neurons. Autonomic neuropathy or wound healing because your white blood cell functioning is reduced, also your blood flow. And macrovascular angiopathy, so like CVD and PVD, peripheral vascular disease, cardiovascular disease. Same thing, we've already talked about this. Hyperglycemia leading to oxidative stress. So review that if you need to. You are most likely going to see a question around something leading to this because it is one of the most prominent problems with diabetes. Okay, you have to understand this because you're going to be treating patients with a lot of this. All the things we just talked about, we've talked about these. Because of their increased susceptibility to infection, they are increased colonization of S. aureus. If you remember S. aureus, when we have, it's prevalent on our skin. I told you that was the one that when you have surgery, it's most likely to get a wound infection. A surgical wound infection is most likely caused by Staph aureus because it's present on our skin. So in diabetics, they have an increased colonization of the Staph aureus. Therefore, if I have wounds on my leg, I'm most likely to get a Staph aureus infection because I have an increased level of a higher number than normal there. I have a weakened immune system, I have a higher level than normal, I have an open wound now because I hit my toe and didn't realize it. So therefore, these patients are going to be at risk for Staph aureus. Remember back, what is our problem with Staph aureus? Is that it's so common, and that we've given antibiotics. What is a common problem? Antibiotic resistance. So these patients are going to be at a higher risk for MRSA and VRSA because of that whole pathology. Also, their natural candida levels or their yeast levels increase. Your diabetics, also because of the glucose that's just oozing from them, those high glucose levels creates a great environment for yeast to grow. So our candida levels are going to increase. They're going to have more yeast infections. Yeast infections can occur in places that they wouldn't normally. They may have yeast infections in folds of skin or behind their ears, or, you know, in places that normally most people don't get yeast infections there. But so you're going to see that. Chronic candida vaginitis may be a presenting feature of diabetes. So in your patients your females that I always get yeast infections. I don't know why, like I just keep it. Like I take the medicine and then that is a trigger as a provider of care to say like, hey, what's going on? If you're getting chronic yeast infections, there's a reason. Like, we need to figure that out. Same thing, just showing the pathology of how one problem of, it's not a little problem, but developing diabetes, especially type 2 diabetes, is gonna put these people at the same risk as type 1 diabetes, okay? So just because the root difference of why they have them is different, your type 1 being your autoimmune, your type 2 being, I developed insulin resistance over time, most likely related to my lifestyle, but those changes, the symptoms are gonna be the same, okay? The complications are gonna be the same. So, especially if they're poorly controlled type 2 diabetes, which a lot of people are. It's a hard thing to do. You're constantly having to stay on top of it, and what happens is that first they just start taking a little oral medication, they're trying to watch their intake, and then they become full-blown insulin dependent type 2 diabetic. So therefore I'm no longer able to use the insulin that I have. And so, what starts out as a little thing could be a very, very big thing, is that all this is saying. It's going to cascade the problems. Same thing with your diabetic retinopathy and blindness. Leading cause of blindness in adults is related to diabetic retinopathy. Leads to renal failure. And then when we have renal failure, activation of the RAS with renal dysfunction compounds problem as their blood pressure elevates. So can you see how all these things go hand in hand? Dermatological complications. So we already said we have like prolonged wound healing and ulcer formation. Diabetic skin spots, like hyperpigmented areas. They may have acanthosis nigricans, tiny hyperpigmented macular lesions. Lipotrophy, which can occur at insulin injection sites. So this is just where, because we give it's sub-Q and like the fatty tissues, they get lipotrophy where that fat like hardens, and then it's like hardened scar tissue almost, and then therefore it makes it to where you can no longer use those sites. My stepsister's a diabetic, and she like has to rotate where, because, and she's like on a pump and everything, so she'll have to rotate where she does the pump, because it does, if it's like, becomes like hardened, like the pad of your, and so therefore, it will no longer absorb that insulin, and so even if you did put it there, it's not gonna function like it needs to, so you have to rotate. Alright, psychological resistance. So depression is 2 times more common in those with diabetes mellitus. There's a lot of non-compliance, a lot of denial. I mean, the society where we live is like we can get whatever we want, whenever we want it, and So just note that there's an increased risk for depression and psychological disorders in your diabetic patients. Psychological insulin resistance is, all that is just refusal to comply. And I will tell you, I do have a lot of patients that just refuse to do it. No, don't want to do that. Okay. Eating disorders are going to be increased. Young women with type 1 diabetes are at an increased risk for eating disorders. What this means, and I can speak because my stepsister was like this. She'd be like, oh, well, I really want that chocolate milkshake. And I know I don't need it, but I'll just bolus myself. And she'd bolus her insulin and up her insulin to cover. So, but when you're constantly doing that, that creates like, and that's called insulin purging. No, that's not called insulin purging. But that does create problems because you're, what? Oh. I thought you were going. Yeah. I was like, what? Are you diabetic? Do you know? I don't know. Okay, so that's not good compliance. They shouldn't be like, it's okay to have something occasionally, but when you're constantly eating things that you know you shouldn't eat, and just covering yourself, bolusing yourself for it, that's not good compliance. That's not gonna create good homeostasis of those blood glucose levels in your body. Prolonged, they're gonna be elevated, okay? But also, insulin purging is where we're gonna restrict or skip insulin usage to stimulate lipolysis and weight loss. So, a diabetic patient can lose a lot of weight through this. So, but it's not necessarily, it can be a good thing, but because weight, excessive weight is, but to an extent, it has to be managed by a physician. So suspect eating disorder in patients with recurrent DKA or chronically poor glycemic control. Strict glycemic control is the goal of all diabetes. So we want to keep everybody mainline, like that's why eating, the candy bar and the milkshake and then bolusing yourself is not a good idea, because we're trying to keep normal levels throughout. So better control is related to decreased risk for long-term complications. Insulin excess is the most common cause of hypoglycemia. So that's our type 1 diabetics. We give them too much insulin, or and then we actually end up dropping them down. Daily exercise, here's your alert. Strenuous exercise can cause significant decrease in blood glucose, leading to hypoglycemia. So, if Jane's gonna go for her morning run, what does Jane need to do? It says it on the thing. We need to reduce insulin before physical activity, make sure that we have a carb source available, and it is a good idea for anybody who's diabetic to have a diabetic ID card or bracelet available. Was it miserable? Awful?
I love
Hard?
it.
Happy y'all sleeping? Well, the endocrine system, sucks, for lack of better words. It's a lot, it's hard, it is. But